Good morning, everyone. I hope I'm audible. Great.
Yeah.
I'm Dr. Deepika Chandok, and on behalf of Department of Conservative Dentistry and Endodontics, BSPM Dental College, Nagpur, I welcome you to the Healing Fest 2020. We would be having webinars daily for the entire month of July, and we hope that you take advantage of this varied arena of topics being broadcasted every day. Firstly, I'd request our head of the department, Dr. Pratima Shenoy ma'am, to say a few words.
Good morning, all. I welcome you all to this Healing Festival on this special day, Doctor's Day. I wish you all a very happy Doctor's Day and all happiness in your life always. As we all know, once you enter the field of health sciences, learning is a lifelong process. The importance of being updated cannot be overstressed. This program, which started as a 2-day lecture seminar, has blossomed into a month-long festival of assimilating knowledge and celebrating our specialty. Through the month, we have among ourselves the best in the field sharing their expertise and also the newcomers who are raring to go. We thank them all for accepting our invitation and being the backbone of this event. This pandemic has taught us that there is much more to life than professional excellence. It is important to celebrate life than merely exist. Few amongst us have shown exemplary talent and enriched their lives with many more achievements other than professional life. In the stars of Endo Galaxy, we showcase and highlight their talents and we showcase and highlight such talents. And believe me, it is amazing to see all they can do. The last part is to celebrate the threat of pandemic itself, to change the gloomy face mask into a fashion statement. We bring to you talented individuals who helped us spread happiness and add zest to life. In the end, I wish to acknowledge and put on records with deep sense of gratitude the hard work put in by all my department friends and postgraduate students. Without them, nothing was possible. We acknowledge the unstinted support by the Honorable Chairman, Shri Ranjit Babu Deshmukh, our Dean, Dr. Usha Redke, and our Vice Dean, Dr. Ramkrishna Shenoy. There are many dear friends and experts who we couldn't accommodate for the lecture series. We regret this immensely and God willing, look ahead for season 2. I welcome all my friends who have joined me today, and it's really because of your goodwill and your support that we are able to do this. I'm very happy to announce that we have more than 500 registrations and we are now live on Facebook, and everyone is looking forward to have a good session. Thank you so much for being with us. Have a happy journey and enjoy yourself throughout the month. Thank you.
Thank you, Pratima Shenoy ma'am. We are truly privileged to have an eminent speaker today with us, Dr. Arvind Shenoy sir, who would be speaking on the topic Universal Bonding, a Myth or Reality. We welcome you, dear sir. We are also honored to have with us Dr. S. Mahalakshmi ma'am, who would be moderating the session. We welcome you, dear ma'am. A warm welcome to all the participants who have joined us today from different parts of the country. Before we begin, a kind request to everyone to please mute their mics and also switch off their videos for better connectivity. Any queries can be put up in the chat box, which would be dealt with at the end of the session. Also, the live session is now available for viewing on the Facebook page Endocons BSPM Nagpur. I repeat, it's Endocons BSPM Nagpur. Now I take this opportunity to introduce our moderator for today, Dr. S. Mahalakshmi ma'am. Dr. S. Mahalakshmi ma'am, as we all know, she is very popular in our field. So she has completed her post-graduation in conservative dentistry and endodontics in the year 1986 from GDC Ahmedabad. She has been in academics since 1990, currently heading the Department of Cons and Endo at SRM Dental College, Chennai since March 2006. She has more than 50 publications to her credit, majority in indexed high impact factor journals. She has authored a textbook, which we all know, Materials Used in Dentistry in 2013, published by Walters Kluwer India, and the second edition came out in 2018. She has also contributed various chapters in different endo-related textbooks. She also has a DST-funded collaborative project under her wing, for which she is the principal investigator. We welcome you, ma'am. And now I request Dr. S. Mahalakshmi, ma'am, to introduce our esteemed speaker for today, Dr. Arvind Shenoy. Over to you, ma'am.
Thank you very much, Deepika. At the onset, I would like to thank Dr. Pratima Shenoy for remembering and inviting me to be the moderator of the session. And I wish a very happy Doctor's Day to all our participants here. And what better day than to start it on July 1st, the National Doctor's Day. It is indeed a privilege for me to introduce Dr. Arvind Shenoy. The topic of his is mainly on bonding. And even though composite resins has been in practice for more than many decades, we still have problems with bonding, right? We all face problems. The main reason is the heterogeneity of dentine. So in clinical situations, this heterogeneous nature of dentine becomes even more difficult. You have carious dentine, you have deep dentine, all sorts of surface in which you have to react. And today, no other person better than Dr. Arvind Shenoy to give it very simple and in a very nice way. Dr. Arvind Shenoy currently is a professor in the Department of Conservative Dentistry at Bapuji Dental College and Hospital, Davangere. He is a restorative dentist and endodontist with more than 30 years of clinical and teaching experience. Special area of interest is, of course, aesthetics, adhesive dentistry, and ceramics. He has over 60 publications to his credit and is a reviewer for several peer-reviewed journals. He is a course faculty for several Indian and international certificate courses on endodontics and aesthetics, and has conducted over 250 lectures and courses on aesthetic dentistry and endodontics. He is also an adjunct professor at Sri Ramachandra Dental College, Chennai. He is the fellow of the International College of Dentists, the editor of the South Asian edition of Philips Dental Materials. He is also editor of textbook of endodontics, principles and practice. So I have attended a lot of lectures by Dr. Arvind Shenoy in many various forums, and I've always found his hall to be always full. And the reason is that he explains everything in a very simple and he just puts the facts in a very simple way. That's why they all love him. So over to you, Dr. Arvind Shenoy.
Thank you, Dr. Mahalakshmi. Thank you, Dr. Mahalakshmi, and thank you, Dr. Pratima Shenoy, Vatsha, and Deepika for having me here today. It's indeed a pleasure to be here today. And I'm hoping that at the end of 1 hour, I can contribute something which will help you in your day-to-day practice. Funny thing is, when you saw the invite, so what was done was in the invite, the first alphabet of the name and the surname was highlighted in yellow. So as it happens, mine ends up being AS or us. So I don't know. I found that to be funny. It really was. Anyways, so I come to you from southern India. There are many of you all who are from different parts of the country and who may or may not have visited us. This is a spectacular part of the country, and these are just some pictures from our part of the country so that you can see exactly what is the kind of nature that we have at this time of the year. Really spectacular paddies. I mean, if you look at these are some rice paddies in cultivation and the sun shining down, there'll be mist, there'll be this light drizzle and nature at its best. Okay, so as I told you, some of the pictures, I'm having some technical issues today, hopefully not with the clinical pictures. So this was me fooling around a couple of months ago before the lockdown. And we visited the wildlife sanctuary, and this is how close to nature we really got at that time, something I'm missing now. And, you know, I would taken this picture in jest at that time, but it really came through a month down the line now that we are under lockdown with all the COVID situation and all that. And this is exactly what I felt immediately after we went into lockdown. But this picture kind of sums up for me what situation we are in now. This is actually a palm tree, and it's been surrounded by another tree which is growing around, and these three, both of them now are healthily living together. I'm sorry, let me just go back. I'm just sorry about that. I really want you to see that and appreciate it, because this is probably the way I feel about our situation right now. So just like these two trees which are intertwined together, COVID and us are going to live together for some time to come. I mean, that's the reality. And we have to manage and cope with that. Lucky to have been part of a team which has helped me through the years. I've been working here for more than a decade now. And, okay, fine. So some images for some reason are going off. I really don't know why, but this is my entire team, the teaching and the non-teaching. And, you know, I really want to give a big shout out even to the non-teaching, because they have been an integral part of helping the whole department. And even today, they are the ones who will make the department function with more work because of the increased load on them with respect to sanitization and all that. In better times, this was all of us. This is not going to happen for some time now, I know, but these are better times with all my colleagues and postgraduates. So thanks to everybody who was there with me and who has helped me over the years. So what is adhesive dentistry? Let's look at that. So Dr. Mahalakshmi spoke about bonding, and bonding is an integral part of what we are doing now. So we've all kind of got used to the concept of etching. The etchant is what we've used most often, and etchant means adhesives. Earlier 3-step and now 2-step is what we used. So OptiBond FL and single bond multipurpose, or you know, these were the two gold standards earlier, 3-step. Now we have add per single bond, say from 3M, and this, both of these are etch and rinse. So you need to etch first and then you need to bond, whether it's enamel or dentine. What came next, and I'm not going generationally, I'm just talking clinically here, was the whole concept of self-etch, which never really picked up in India. And it's really unfortunate, because if you ask me, Clearfill SE, that's the 2-bottle system from Curare, is one of the best bonding systems which is available. But somehow India never went into the self-etch kind of concept for very long. And now what we have is the so-called universal adhesive. And these universal adhesives, or I prefer to call them multi-mode adhesives, but let's call them universal adhesives for now, essentially are adhesives which are a combination of both of these. You could use them in etch and rinse mode, or you could use them in self-etch mode. So, you know, if you combine both of these together, you get a universal adhesive. Effectively, it gives you the best of both worlds. Now, we work with different clinical scenarios. So we could have caries, as Dr. Mahalakshmi very correctly pointed out. You know, there are different substructures we work with. So we could be working with a carious tooth. We could be working with a tooth which is predominantly dentine, like we have here. We could be working with something which is predominantly enamel, like we have here, a veneer prep. Or we could be looking at something where the enamel is altered. Now this, for example, is altered enamel, where the enamel could be hypomineralized or could be fluorotic. Now we need to bond all of these, not only with composite, but we could be placing crowns or bridges. Now this could be metal or PFM, as in this case. There could be ceramics, different versions. There could be, say, glass ceramics. There could be zirconia. In zirconia, you have, again, different varieties. You have the more translucent, low-strength zirconias. You have the high-strength zirconias. They could be layered. They could be monolith. Or you could have just veneers. They could be, again, feldspathic, or they could be lithium disilicate. Or now, when you have all these restorations, you always have some conditioners for them. So you could have ceramic primers. You could have alloy primer. You could have a multi-primer which works both for alloys or for ceramics. or you could have a bond activator. Now, all of these are available in the market today. These are supposed to increase the bonding to these restorations. And finally, when we cement these restorations together, we could be cementing them either with glass ionomers, resin modified glass ionomers, or with resin cements. Now, when we talk about resin cements, we have self-adhesive resin cements and adhesive resin cements. So this is the kind of combination we are talking about today. And if I talk about the multiple manufacturers, so there are about 10, 12, 15 manufacturers making all of these. So if you look at all these products together, and now I need to decide what am I going to use for which situation and what works and what doesn't, the first thing which comes to mind is this, followed by this, followed by this. Yes. Yes, my friends, this is exactly the scenario we are in right now. Half the time, it's a confusion about are we using things right or not. Now, some of us do realize this. Some of us are using things without realizing that we are not using the right combination of materials. So the point is, let's say if I want to look at one clinical scenario. Now here I have primarily enamel, I'm bonding veneers. I have 3 different bonding systems available, etch and rinse, self-etch and universal. Obviously I'm not going to use a alloy primer here, but I could use a ceramic primer, a multi-primer or a porcelain bond activator. And I have all these 4 cements available for luting or bonding. What combination works? Now, in fact, if you look at it, I could use any of these 3 in terms of the conditioner, but I cannot use the self-etch bonding. So if you realize now, self-etch has gone out because for this, I need to use etch and rinse only. Now I could either use a pure etch and rinse or I could use a universal, but self-etch is out. Just as alloy primer is out, you use one of these 3. But what's also important is none of the cements can be used for this ideally. So for this, I need to have a separate resin cement, which is a light cured resin cement, which is specifically used for veneers. Now, for me, the important thing as a clinician, and I'm sure for most of you all also, is it really possible? And I say one way and one work that would make it truly universal, or what I call it. Lecture is just whether this is real, irrespective of manufacturer. Here I'm showing you one manufacturer, but we are going to be discussing all manufacturers as we proceed in our lecture. There is a articles in British Dental Journal which were published by Berg, where they have evaluated millions of restorations to find out success and failure rates, and they have divided it into categories like resin, glass ionomer, premolars, canines, incisors, molars. I really recommend that you should go through them. It is really enlightening to go through it. I'm going to just present a few of these so that we have a better understanding of what we are doing and whether it works or not. So what they did was they evaluated all these restorations and they tried to come up with some data. Now, one of the things which they found was, at what point we re-intervene after you've done something. So I've done a restoration today. At what point do I actually need to go back and re-intervene? And he compared that for different, and they compared that for different restorative options. Now, if you look at the restorative options here, you'll find that what performs the best is crowns, and what performs the best is glass ionomers. Composite resin is somewhere in between the legend here, and you can see the graph. But what's more important is, if you start off from the timeline 0 and you go up to 15 years, you see restorations almost nearly 30 to 50% of them would need to be changed or repaired within 10 to 15 years. Now, this is a good figure. In India, this figure is in the low 5 to 10 years, according to me. Now, that was for patients below 40 years of age. What happens with patients over 40 years of age? Now, if you look at over 40 years of age, again, you find, now, this is very important for me because glass ionomer is one of the materials which is recommended in older patients, especially in geriatrics. But here you also see that the failure rate with glass ionomers, or the need for re-intervention, is much higher. Again, crowns perform much better, and composites here somewhere in the middle. Also important to note here that if you notice MODs, So MOD restorations generally don't do very well. I mean, that's common sense. The more tooth structure and the more marginal which you remove, the more the likelihood of you needing intervention. Even more critical, and I've been saying this for a long time now because this really matters to me. You know, beyond studies which are done in the lab or clinically, what is important to us is survival. How long do these restorations last, and how long do these teeth last, very frankly? And this is very important. At what point restored teeth in molars get extracted? And in patients over 40 years of age, you find that nearly action at some point of time because these restorations are bound to fail. And what is the failure rate of the different restorations? So at 10 years, let's look at a ballpark of 10 years. Amalgam survival is 51%, composite resin survival is 43%, which is still excellent if you ask me, provided you do things right. But the failure rate again of Lhasa and survival rate is only 37%. Crowns is 63%. So crowns obviously have a longer longevity and need less intervention, but at the same time are also much more destructive. So I'm not recommending crowns. When we talk about crowns, let's also think about onlays, as I will talk about a little later. So in the simplest possible way to explain what adhesive dentistry offers me, if I look at a case, now this lady needed aesthetic correction. Her smile was impaired both because of hard tissue and soft tissue issues. So I'm not going to go into the treatment planning details, but we planned veneers for her. Minimalistic preparations as much as possible in enamel. You don't want to expose dentine. I'll explain to you why a little later. Good isolation is required for both the recording of the impression as well as the cementation. This is a retraction paste which is being used, does the same job. And this is the kind of clean scenario you need before making an impression or before doing any bonding. If you would want to place a rubber dam, even better. And this is the prep. You should have definitive preps, minimal but definitive preps as much as possible intra-enamel. And this is the final result which we got. And if you see the difference in the patient's smile, let's just look at the, just a close-up of the smile. You can see the difference in soft and hard tissue, in soft tissue as well as the dental picture. And when you look at the patient's smile, I mean, there is a significant difference. Now, the point here is these preparations are only in enamel. There is absolutely no retention form, mind you, and you are just retaining them by bonding. But you will be really interested to know that the success or the survival rate of ceramic veneers is in the 90%, high 90s. It's 93 to 95% according to most studies. At 20 years, it is around 82%. So at 10 years, it's 90+%, and at 20 years, it is around 80%. That is a very, very high survival rate. So we have a restoration which is just bonded, has no retention form whatsoever, but yet it has the highest survival rate. And there are two reasons for that. One, minimal tooth prep. Two, intra-enamel preparations where bonding is really, really predictable. If we go into dentine, what happens? Now, this is important. Now, this was a clinical study done by Gurel, in which the failure rates are here. So if your preparation margin is enamel, the failure rate is only 3.1%, whereas if your preparation margin is in dentine, it is 89.3%. Now that is statistically highly, highly, highly significant. Of course, if you look at the numbers, you'll find that the preparation was in dentine only 28 cases. And that is the reason, I mean, in 28 teeth. And the reason for that is, as a restorative dentist, that is something I want to avoid as much as possible. And even they have done that. But again, if you look at the preparation depth, and this is something which people don't pay attention to. If you prepare in dentine, and here there is a substantial number of cases which do go into dentine for whatever reason, then again, the failure rate is very high, 31.9, again, statistically very significant. So what it tells us is when preparations are in dentine, and especially when margins are in dentine, the failure rate of restorations tends to be higher. This is especially true with veneers. So what do we do in a case like this? Now, in a case like this, for example, if I go for a crown, as many people would say, I would lose all this enamel which exists. I mean, that's really criminal. The best thing for this would be a tabletop or an onlay, and that's what exactly we prep for. But I just told you a lot of this preparation is going to be in dentine. I mean, I didn't choose to make it, so it was already exposed. So what now? How well does it work? Or would crown still be a better option? So this is an Emax onlay which has been placed on this tooth. And one of the great things about this is you can see the kind of wonderful margin which you can get, beautiful seal of the margin. It blends in so imperceptibly. What is most critical here is not the amount of dentine exposed here, but the margin. We have an intra-enamel margin. You have an entire margin which is in enamel. So effectively, I can seal this restoration completely. And that is very, very, very critical. Once I seal this margin effectively, I can control the failure of the dentine bonding. So it is much better to have a margin entirely in enamel. And this is something we really need to focus on for most procedures. And again, the reason I talked about crowns and inlays, if you look at the survival percentages of, now again, I recommend you go through this article, but if you look at survival percentages, for crowns, if it is 51.2%, it is 82.9% for veneers. And again, for inlays, it is in the high 80 to 90%. So inlays and onlays are much better procedures to think of when compared to a crown. And having a margin in enamel is really critically important for us. So coming to universal adhesives, what are they basically? I mean, basically, I have told you they are either a single bottle, no mix adhesive system, which can be used in total edge, self edge, or selective edge mode, depending on whatever the clinician wants. Let's just try and look at a few of the options which you've had in bonding so far. So we first had the etch and rinse 3-step, then we had the etch and rinse 2-step, that is just etch and then the bonding and the primer and solvent, everything is in one bottle, which most of you all are using, I'm sure. Then we had the self-etch systems, and I told you the 2-step self-etch systems again are the gold standard. One example I gave you was Clearfill SE. You had a lot of the single-step self-etch systems in the market. A lot of people were using these. They didn't want to use the 2-step, but the 2-step was much better clinically. And now what we have is what I call the multi-mode. The multi-mode can be used either as etch and rinse, or it can be used as self-etch or selective etch. So let's just go a little bit into that. So if you look at compositionally, this is the composition of some of the important systems which are available in the market. And one thing which you will find is common to all of them, or most of them, I won't say all, but most of them, they contain 10 MDP. So now this is a molecule which is very important for most manufacturers, because this has two very critical facts. One is it can actually bond to hydroxyapatite, to the calcium, and it is also stable over time. So one of the problems with bonding, especially to dentine, has been bond degradation. You want to create what is known as an acid-base resistant zone, and you don't want degradation because of hydrolysis. Now, the 10 MDP to a large extent helps you with that, because this bond is more stable over time. So I'll talk a bit about this molecule next. The next is silane. Now, silane, as we know, is required for bonding to feldspathic porcelains, glass ceramic, lucite reinforced, or lithium disilicate reinforced ceramics. Now, two of these systems, Scotch Bond Universal and Clearfill Universal, have silane in them. So if you use this bonding system directly on glass ceramics, you technically wouldn't need silane to be separately added, which makes them kind of universal. Also, 10 MDP is known to help in bonding to metal and zirconia. So if you look at these two, since they contain 10 MDP and silane, they would bond to metal, zirconia, and glass ceramics by themselves without the need for an additional primer or an additional step of using a primer. Whereas the others would require a separate primer. So when we're talking about are they truly universal, So these two probably are and the others aren't, but please bear with me till the end of the lecture because this is not the end of it. Now, the other thing which you will notice is most of these manufacturers have HEMA, which is a hydrophilic primer, except one that is GC from Premier Bond, which doesn't contain HEMA. Now, this is clinically relevant. Most systems use HEMA as the hydrophilic primer because it's got multiple advantages. But the clinical importance of that is if any system contains HEMA, there should be no time lag between bonding and application of the composite. So if you finished your bonding, you don't want to wait for another 5 minutes before you put the composite because you start getting blistering on the surface and then your composite will separate from the bonding or it won't join the bonding agent very well. So it is important to remember that when you're working with most systems. Now, one of the systems I said doesn't have HEMA. So any system which doesn't have HEMA, it requires a very, very strong air drying step. So, you know, when you're drying the bonding after application and before curing, generally most people recommend that you should dry gently. If there is no HEMA in the system, it requires drying to be very forceful, not gentle, because you really want to disperse any moisture from the surface before you cure the bonding agent. Now this is 10 MDP, and again, I'm not going to go too much into the chemistry because we have very limited time. But one of the most important things about it is it has the potential to interact with hydroxyapatite. So there is an adhesion decalcification concept. So depending on the pH of an acid, like say if you take phosphoric acid on one side and if you take 10 MDP on the other, both of them have a phosphate radical which is going to attack the hydroxyapatite, leading to calcium release, and then the phosphate in these radicals will combine with the calcium to form a calcium phosphate salt. Now this happens with both phosphoric acid as well as with say 10 MDP. The difference is phosphoric acid is very, very, very highly acidic. And so the salt which is formed is not very stable and it tends to break down. So what happens is when you etch with phosphoric acid, you end up with leaching of the mineralized component and you get etching pattern. Whereas if you use 10 MDP, which is again a phosphate monomer, you get a stable calcium phosphate salt. So this actually can bond to the hydroxyapatite. Not only that, it is stable over a period of time and it has also got this potential to bond to zirconia. So this 10 MDP makes it a little better in terms of stability of bonding. The type of bonding you get is better and also it bonds to metal. So that's why it is used most often by most of the manufacturers. Now, another important thing for us to understand, because remember I told you these can be used in etch and rinse as well as self-etch. So if you can use it in self-etch, you also want them to work on enamel in self-etch mode. So the pH becomes important. Now, when we are working with etch and rinse, you're using a phosphoric acid step for etching the enamel. And as I already told you, the pH being very low, it etches the enamel. But if you're using these agents in self-etch mode, are they capable of conditioning enamel to get good bonding to enamel? So if you look at the pH, almost all of them have a pH which is about 2 going up to 3. So the pH is higher, which means that the effect on enamel will not be as good. So these work very, very efficiently with dentine, but the effect on enamel is not that good when used in self-etch mode. You need to remember that. And we will talk about the clinical implications of that going forward. So are they truly universal? Now, this is a chart which I'm going to revisit again at the end of my presentation, which tells you about what each of these systems is capable of doing and not capable of doing. But let's revisit this later. I just wanted to put it out here because there are a lot of no's in this. I wanted to see that. Not every system says yes to everything. So let's first start with clinical parameters for day-to-day work. What we do, that is we work with composite resin, so resin composite. And as Dr. Mahalakshmi had said, it's not always hunky-dory when we are working with teeth. Now, all the bonding systems, or most of the bonding systems, are designed to work on normal dentine. I really need you to understand that. So they don't go and make bonding systems for caries dentine or sclerotic dentine. Primarily, you would design it to work with normal dentine. So most of these bonding systems are designed to work with normal dentine. Unfortunately, in our line of work, you would have enamel lesions And then you would have caries infected dentine and then caries affected dentine. Again, because of paucity of time, I cannot discuss the details, but there are different degrees of demineralization here. And so this is not exactly normal dentine. So you have different clinical scenarios, like you may have a clinical scenario like this. Now, in this one cavity, for example, you have what appears to be arrested, what appears to be sclerotic dentine, and what appears probably here to be active caries affected dentine. Now, all of these are together with maybe a bit of normal dentine, and whatever bonding system you use is expected to work on all of these. Or you could have a clinical scenario like this. And this is very, very, very likely nowadays with the modified caries management techniques that we use, where we have, this area of caries affected dentine. Now, if you can see, if we remove this, we are going to end up with an exposure. So if this patient is essentially asymptomatic or has reversible symptoms, we would go in for a restoration here with a nice seal so that we can protect the pulp. But the dentine again is altered. You could also have a clinical scenario like this. Now, NCCLs are a pain. NCCLs are the real pain to handle clinically because the multiple options and failure rates are very high. And one of the reasons is because the enamel margin is not always present in the cervical area and there's a lot of sclerotic dentine present. You could also have clinical scenarios like this. Now, this looks like 3 straightforward class 2s, but if you look at them closely, if you see here, there is a nice thick margin of enamel. Okay. If you look at this, there is a little thinner enamel. And if you look at this, there is hardly any enamel. So when we go back to talking about the importance of peripheral enamel seal, these 3 restorations are going to behave differently. The cavity which doesn't have so much enamel in the cervical margin is going to be more prone to be leakage there, and the clinical technique may have to be modified accordingly. So there are multiple options for restoring these, like, an open sandwich, a closed sandwich, or a full composite restoration, or maybe a flowable composite, or maybe a heat softened composite. There's so many multiple options there, and each one would have to be taken depending on the amount of enamel available at the margin. And last but not the least, okay, this was a case of, again, sclerotic dentine. I'll show you the case a little later. Right. Now, this is what most of us face on a day-to-day basis. The question is, how much caries do you remove? And now this was the first step after you open the cavity. Now there is some caries infected dentine here, which is totally demineralized, which needs to go. But then you end up with this. This is caries affected dentine. Do you want to remove it or do you not want to remove it? Now, this is an important thing, and everybody needs to understand that we are getting it wrong very often. Shenoy has done a lot of work on this, and in this review, what they found was when they interviewed clinicians, they found more than half of them did not do it the way it is supposed to be scientifically. They did it the way it was told to them anecdotally, or it was taught to them in college. And I'm really sorry to say this, but after being in teaching for 30 years, I still find that many colleges are still teaching caries removal techniques which belong to the era of Jesus Christ. I mean that as a joke, but what I mean to say is these techniques were taught in 40s, 50s, and 60s. We have evolved so much. There's so much more science available to us. And one of the most important things I really want you all to understand, if you have not been doing this, and this data has been out there from way back in 2006, 2008, it is not recent data. And that is that even with incomplete caries removal, as long as you seal the cavity completely, that means your margins in enamel and your margins are sealed completely, you can actually arrest or reverse the caries. And there are multiple techniques to do this. Selective caries removal, there's Hall technique for pediatric patients. So you can have the 2-step selective removal or the 1-step selective removal. I mean, there are plenty of articles on this which you can discuss, which I really recommend all of you should read, from Advances of Dental Research in 26. This is for the postgraduates maybe attending. So again, sorry about that, but The most important thing is it is safer to finish the cavity margins in clean, sound tissue. This is very, very important. So get margins in enamel and get a KO surface seal. And by and large, remember I told you, caries affected dentine has got lesser mineral content. Our studies have shown that etch and rinse works better with caries affected dentine. Okay, so one is the enamel is going to get etched, so you get a wonderful seal at the margin. Second is even on the dentine, etch and rinse would probably be better. However, having said that, sensitivity is a very, very real issue if the bonding is not done correctly. So be careful, and maybe selective etch may be a better option for most people. Okay. Now, if you look at a case like this is courtesy of my colleague, Dr. Arun. So what you want to do is basic caries removal. Then you remove the caries infected dentine, and now you are left with a cavity which is essentially having a nice, wonderful seal on the periphery because there is a nice border of enamel, but you still have that caries affected dentine left behind. That's okay, leave it there. Please understand, this is a class 5 on the buccal side. If you try to excavate it anymore, you're going to get a nice, beautiful pulp chamber exposure. Not a pinpoint exposure, but an entire pulp chamber exposure. So it is much better to be prudent about caries removal strategies. Now, these are the things which we need to consider when we are working with composites and bonding. Are you going to use etch and rinse, selective etch, or are you going to use self-etch? As a rule, more the enamel you're working with, etch and rinse is the way to go. More the dentine, deeper the dentine, self-etch is the way to go. If you have a combination of both, like a deep cavity in posterior, selective etch is the way to go. Surface conditioning of enamel. Now, suppose you choose to use self-etch system with enamel, it might be a better idea to roughen the surface with a burr. If you are doing, say, a diastema closure where there is intact enamel and you want to use self-etch, and why would you want to self-etch? Now, this in the era of COVID, this is important. In the era of COVID, you would want to avoid using three-way syringe. You want to avoid using etchant because you need to wash it. There's going to be splatter. Even if you're working under rubber dam, that's something you want to avoid. So in this era of COVID, the self-etch is going to become much, much, much more important to us. And I'm going to give you a few tips today about how you could incorporate self-etch even with enamels. One of the things is, if you're using self-etch on enamel, make sure that you remove a little bit of the surface layer of enamel. You know, you could use even a micromotor, an electric motor to just roughen the surface, or you could use a disc which is coarse. You just want the superficial surface to be removed, which is hypermineralized, so that it is easier for the self-etch self-etch conditioner to work. The second is the application time, and we will talk about it in a little bit of detail. And I don't know how many cases you all see of fluorosis or hypermineralization, so I'll just briefly talk about that. Type of dentine, I've already spoken to you. Caries affected dentine, I've already spoken to you. But let us also look at it in terms of what options we have. One is you could have selective etch, as I told you, lot of dentine, also a lot of enamel. Selective etch, primarily enamel like veneers, or diastema closures, etch and rinse, and self-etch for everything else, especially when there's a lot of dentine involved. So these are the three options which you have. Now, if you are going to be using selective etch, the type of etchant that you use becomes very critical. You need an etching gel which actually stays in place. So it has to be a little viscous. It has to be able to stay in place without slumping. So the type of etchant which you use becomes very critical. Now, are there any things which you can do? Now there is this beautiful study, and there are other studies also which have corroborated that. What if you did self-etch for longer than the manufacturers recommended? Now, most manufacturers recommend, say, 20 seconds. Now, here, Clearfill Universal and Single Bond Universal, both are recommended for 20 seconds. What they did in this study was, they actually increased this etching, the self-etch time to 40 seconds. So now they have three groups here. In one group, they've used etch and rinse. The second group, they've used self-etch for 20 seconds as the manufacturer recommended. The third group, they've used self-etch for 40 seconds. And surprisingly, what you find is that if you increase the self-etch time to 40 seconds, you get a much better etching pattern on the enamel. So if you're working with enamel and you want to use self-etch, one recommendation, first just remove the top surface with the disc or something, and then use self-etch for longer than recommended by the manufacturer. You can't go wrong with that. You'd probably get better bonding. So this is one of the tips which I can give you for that. But in these kind of cases, it becomes a little tough. And, again, it's a big topic by itself. But one of the things I can tell you is that if you have cases like this is amelogenesis imperfecta, and you really need to look at the surface enamel and see how stable it is. And you may need to remove a lot of it, which is chalky or porous and is not amenable to bonding. The second thing, again, here in cases like this, you might want to think about whether a full coverage restoration may be a better option. But if you want to bond to these surfaces, one thing is deep proteinization with 5% sodium hypochlorite. Now, before you do the bonding, you apply 5% sodium hypochlorite. There are not many studies on what works best here, etch and rinse or self-etch. But after deproteinization, if you use self-etch, it works. Again, you could increase the time of self-etch like we've done earlier, and you might get better results with that. There are not that many studies which have worked on this, because obviously it's difficult to get that many extracted teeth which are hypomineralized or hypocalcified. Ideally, you would want to avoid the restoration altogether, and if you have a case like this, the best treatment option would be to go in for, would be to go in for bleaching with, you go in for bleaching, and you go for micro abrasion and things like that, resin infiltration. That is the way to go. Unfortunately, the image is lost. But if you have to go in for restorations, then these are the options. One of the most important things is, now, if you have these discolorations, remove only minimal enamel. Don't expose the dentine again, and you can bond very well to it, and the results are quite spectacular. So minimal intervention again would be the game with these. Now, what if you are working with NCCLs? And as I told you earlier, they can really be a pain. And so these three studies are all clinical studies, and you can look them up later, which compared some of the parameters which we generally look at. What would you prefer? Etch and rinse, selective etch, self-etch. One. What restorative material would you want to use? Do you want to use a glass ionomer? Do you want to use a composite? Do you want to use a flowable composite like a bulk fill flowable? Do you want to use a viscous glass ionomer like, say, Equia Fort from GC? Or do you want to use a regular nano composite? So there are multiple concepts and options available here. So based on most available literature, few things I can tell you. There's not much of a difference between, say, a two-step self-etch and an etch and rinse. So two-step self-etches work wonderfully well here, except maybe over a period of time, the marginal discoloration is a little more. There's a study, I think, by Pumans. There's a 13-year follow-up where they have found that, effective, it works very well, self-etch. The other thing is, when you compare etch and rinse with self-etch, both are kind of similar. The viscous glass ionomers tend to have a little inferior performance compared to composites. So if you're using glass ionomers, the failure rate again may be slightly higher. And whichever composite you want to use, it doesn't matter. You could use a bulk fill flowable, or you could use a conventional nano-filled composite. Both of them work very well. So that's the data on these. So these are the options which you have, and this is how you would take care of it. Now, this one case I will show you, which was treated with glass ionomer. So one of the things which I really encourage everybody to do is make sure that you retract, and with whichever glass ionomer that you happen to use, the conditioner is very important. So I know most people use a glass ionomer without the conditioner, but the conditioner, and again, that's a separate conditioner. I'm not talking about the bonding agents now. I'm talking about every glass ionomer has its own conditioner. So you would be much better off using the conditioner with the glass ionomer. And this is the final result. As opposed to that, if you want to use composites in cases like this, these are 3 class 5s together. A lot of them are abstraction lesions. So you need to check the occlusion and correct that as well. Oh, okay. Sorry. One tip I can give you is, if you have cases like this, what you want to do is you want to bevel this enamel margin. So it is, okay, so what you want to do is bevel the enamel margin. Oops, I'm sorry, small problem here. I have a small technical issue here. Just give me a minute, please.
Sure, sir.
Okay, so I have a problem with the system.
So can you please try exiting the screen and
No,
resharing
no,
again?
it doesn't.
Okay.
Okay. Okay, it really looks like I'm going to have to shut down and rejoin in. Can you just allow me to do that?
Sure, sir. Sure.
I'll rejoin in. Just give me. It'll be done in a minute. I'm sorry, there's
Definitely,
no
sir.
other
We'll
option.
wait
Yeah.
for you. Not a problem. So Dr. Shenoy sir will be joining us shortly. I'm really happy to announce here that we've crossed more than 600 registrations from India and abroad. So thank you very much for an overwhelming response. And please log in every day at 11 o'clock for more such enlightening sessions. We'll begin in just a minute or two. Thank you for your patience.
Okay, thank you for that. And sorry again. Am I audible now?
Yes, sir, you're audible. Please go ahead.
Okay, great. I'm sorry. Yeah. Anyway, so Now, one of the things that we need to look at is variability with these, right? So before we were talking about the class 5 where that hunger. So when you're working with class 5, one of the thing is 17% EDTA for 2 minutes works very well if used on sclerotic dentine before bonding. So if you're working on class 5 and you're doing self-etch and you have sclerotic dentine, then what you want to do is maybe use 17% EDTA for 2 minutes to just condition that dentine before you bond it. Now, this is the application times for the different universal systems. Now, as you can understand, there is a lot of difference, but one of the things which is common to almost all is they expect rubbing. So you need to scrub the surface, and this mode of application is very critical when you're working with the a universal bonding system. So the time as well as the mode of application is very important. Now, this technique is different for different systems. You can't mix and match. So this, for example, is single bond universal. It needs you to apply and rub the adhesive for 20 seconds. Whereas if you take a premium bond, it is leave undisturbed for 10 seconds. Okay. And again, can you see here, maximum air pressure? They want you to have maximum air pressure. Remember I told you, this is one of the systems which doesn't have HEMA. So that's why maximum air pressure. Whereas here you have 2 separate codes for 10 to 15 seconds per code. So each system is different. And I know many of y'all think, what the hell, what difference does it make? Just let's apply it and cure it. It makes a hell of a lot of difference. Now, if you look at this statistic, what they've done here is they have followed manufacturer's instructions, or they have shortened the time for 3 different systems: Scotch Bond, Premium Bond, and Clearfill. And for some manufacturers, you will see here, for example, this is when you're using Premium Bond with manufacturer's instructions. You see how much the bond strength falls when you use it for lesser time. So some manufacturers, the difference is not so much. This is single bond universal, for example. The difference is not that much, but for some manufacturers, the difference is significant. So I would recommend not altering the manufacturer's time for application, making sure that you scrub it properly and evaporate the solvent very well. Again, when it comes to evaporating the solvent, the recommended time is 5 to 10 seconds. But if you increase that to 15 seconds, you will get better results. So to just sum up, when we're working with composites, first, the time, if you want to use self-etch, maybe you want to double from 20 to 40 seconds, you will get better results on enamel if you're not using selective etch. Second is application the correct way. That means you have to keep active application. It's not just apply and leave for most of them. Some of them it will be apply and leave. If it's a non-HEMA containing, you want to apply very heavy pressure while drying. For all others, it is light pressure, but again, you may want to increase the drying time from 5 seconds to 15 to 20 seconds. And also the curing light, there is all the difference. So I recommend having your curing lights tested regularly. In this era, we want to modify techniques. So like say, for example, if I cannot place a bridge here, or I cannot place implants here because of, the COVID requirements and all that, very easy to make an adhesive bridge. So all we've done is, there was already an MOD with amalgam. I've just removed the amalgam. And we use a fiber here. We've used Everstick from GC. So we've just used fiber. So you first use bonding, then you put a flowable composite, then you put this fiber in here. Then I've just taken another piece of fiber across here to give more support to the pontic. What I've also done, this is my own modification here. I have taken a band and I have pushed it underneath so that, it doesn't, you have something against which you can build up the composite. Otherwise, you're going to have all of it slumping onto the tissue. And then you go ahead and build up. This is just a regular nano composite I've used here. This is Genial from GC, which has been used here. You could use anyone. Finishing, polishing, and this is how it looked immediately after. This is a one-step bridge. And this is how it looked after finishing and polishing. So you have a bridge in one session. It takes maybe an hour's time and you're done. And this is an 18-month follow-up I want to show you of the same case. Okay, one photo not seen. Hopefully the others will be seen. Right, this. Okay, here we go. So this is an 18-month follow-up of the same case. and you can see it's holding up pretty well. There's a little bit of discoloration on the label, which you can't see here, but you can see the bridge is holding up pretty well. So at 18 months, this is the result with an adhesive bridge. So it's an effective tool. Bonding and universal adhesives work very well, provided you know how to work with. And I think I've given you enough tips about that. So now that was about bonding to the tooth and about bonding restorative composite resins. But what about bonding to now ceramics? Because we work a lot with ceramics. So let's just look at a case to start with. This lady had 2 missing congenital lateral incisors. There was some problem with the orthodontics, which was done. And then finally, after ortho was done, though there was space for the laterals, there was tipping of the roots, which meant that we couldn't place implants without again going in for orthodontics. And the patient just was not willing to wait. So we had to do a slightly destructive procedure. We had to give her bridges at an age when she was quite young. But clinically, there were no other options. There was also a significant lack of bone. So after redoing the ortho, we would have had to do bone grafts and then put implants. So we chose a bridge here. Sorry. So this is the prep and the bridge. Both of these are lava zirconia from 3M. This is layered zirconia, high strength. And this is how it looked in 2013, I think. Yes, 2013. This is how it looked in 2014. This is how it looked in 2015. You can see how the tissue starts, kind of, okay, sorry, building. Okay. This is 2020. Thankfully, some of the pictures are seen. I really don't know. This is the first time ever this has happened to me. There is some issue I need to fix, but bear with me. So this is 2020. And what you can see very clearly is now in 2013, when we did it, there's not an ovate pontic. It was just a pontic which was on top of the tissue. And as we've evolved from there to 2020, you can see how the tissue has grown around that pontic and makes it look like an ovate pontic, much more natural. This is what the body gives you if you are careful with the work that you do. This is a parietal view. You can see how well the tissue is integrated with the bridge, and 7 years down the line, it's functioning very well, and no reason why it shouldn't function for longer. Now, what we have used here, as I told you, was zirconia, right? And we have to bond this zirconia ideally to this teeth. So the question is, how exactly are you going to go about doing that? So one option is I use a universal adhesive. Remember, it contains MDP, so it can bond to this zirconia. Or I could use the previous etch and rinse, like say Scotch Bond, along with a primer. Okay. Now, if I use a primer, the primer contains the MDP, which this Scotch Bond doesn't have. So I have 2 options, either use a universal or use one of these. Now, the other thing is, I also have options when it comes to cementation, right? So when I have to cement it or bond it to the tooth, I could use now what is known as a self-adhesive. This is U200 from 3M, which is a self-adhesive. That means it bonds to the tooth without any additional bonding to be done on the tooth. You don't need to etch or bond the tooth. The cement itself will automatically bond to the tooth. This is self-adhesive. You have adhesive cements. These are resin cements, which are adhesive. They bond to the tooth, provided the tooth has already been bonded using a bonding agent. So you need to etch or self-etch and bond the tooth, and then this resin cement will bond to that. Now, I know common sense seems to tell you that why do all this? The self-adhesive will automatically bond. But the bond strength of self-adhesive to the tooth is usually much, much lower. So if you want to get a good bond to the tooth, then you want to use these self-adhesive cement. Or why go to all that headache? Why don't I just use a resin modified glass ionomer? So at the end of the day now, I need to decide what I am going to do. And in order to know that, it is very important for me to know the materials which I am using. Now, what we are using here is a high strength zirconia. But I want you to understand that manufacturers have different types of materials. For example, there's a company called Katana. They have Katana HT, which has a strength of 1194, that is high strength. But they also have Katana UTML, which is 688. And they have other products also in between. Now, compare that to say EMAX, which is a lithium disilicate glass ceramic, which is only 460. Can I use the same approach for all these materials? The answer is no. The lower the strength of the material, the more bonding it requires. The higher the strength of the material, the more this thing that you can lute it with, say, a glass ionomer. So when I decide to use one material for restoring, I need to understand exactly what is the strength. Now, as you can see here, the strength of different materials is different. See here, UTML is 557, STML is 748, and Emax is 427. So one of the problems I have seen in my interaction with people across the country is people just don't know what material they're using. If I ask them, what are you using? The answer which they tell me is, I'm using a metal-free ceramic. Metal-free ceramic is not an answer. Properties it has, only then you can use it right. Now, what happens in the bargain is, one of the best materials for anteriors is Emax. It is very, very aesthetic, but across the country, I find a lot of people don't use it simply because they think it fractures. And it fractures because they're using glass ionomer to lute it, which you cannot do. You have to bond it. So if you bond it, I can show you 15, 17-year results with lucite reinforced ceramic, which are weaker than lithium disilicate. That is Empress, a material which predated Emax. I can show you 15 to 17-year results with that, which is still functioning. So if these materials fail, it is because we are getting it wrong. What are we using? I need to understand that before I can decide what am I going to fix it with. And if you look at this article by Donovan, what you find is, if you see the fracture percentage, the highest fracture percentage for single crowns is actually for layered zirconia. And it is not at all bad for monolithic Emax if it is done correctly. But for FPDs, the highest fracture rate is here for monolithic Emax. So Emax is not really good for bridges. It is extremely good for single units, especially in the anterior, and the aesthetics is superb with layered Emax. And if you see for layered Emax single units, the fracture percentage is just 1.83. And for monolith, it is only 0.91. So if I am going to use the right material, okay, then I will get the right results. Now, interestingly, what the people are going in for monolithic zirconia. Okay, so I also needed to understand that for onlays, the fracture rate is only 1.01%, something I told you earlier. So as I told you, as the strength decreases, there is more of a need for bonding. Now, if you look at the left side of the screen, you see feldspathic and IPS, Empress and Emax. They have strengths of 90, 140, and 400. But I also showed you veneer cases which are done with these materials, which withstand with a success rate of 82% over 20 years because they are bonded. So as you are going towards lower strength, you cannot use glass ionomer, you actually need to use bonding. And internationally, what you see now is, if you look at the kind of material choices which are made, so you will find that lithium disilicate is used predominantly for the anteriors and zirconia is used predominantly for the posteriors. Okay, so what options will you choose depends essentially on which material you are going to use. And these are the things which are of importance to us when deciding how well the restoration will last. And I just want to give you an example of what can happen. This is what can happen. This is the kind of catastrophic failure which you get even with high strength zirconia, the layering porcelain fractures. And this is not uncommon. This is another case. There was a monolithic it fractured, and then it was replaced with zirconia. Okay, so this is a bonded crown. This was not done with a universal adhesive. This was done with an older adhesive, and it was done with a metal primer, that is MDP finally, but not a universal adhesive, because back then universal adhesives were not available. This is the first generation of resin cements which was used, and 12 years later, 12 years later, it's still in function. No fractures, no failures, because attention was paid to exactly how we cemented or bonded it. So if you look at this chart now, there are only a few things I needed to focus on. So first, if you're using feldspathic porcelains or you're using lucite reinforced porcelains, you need to etch it for 60 seconds. If you're using lithium disilicate, then you need to etch the inner surface for only 20 seconds. Okay. If you're using zirconia, you have to sandblast it. Now, sandblasting can be done chairside, but most of the time it is done in the lab. So either you can sandblast it, but even if you sandblasted it, and this is very important, after you finish the trial, you need to either sandblast it again, or you need to clean it with something called IvoClean from IvoClare, or you need to clean it with 5% sodium hypochlorite. Now, this is very important. If you're using zirconia or alumina, though it may be sandblasted by the lab, once it comes back to you and you try it into the patient's mouth, you have salivary contamination. So either you need to sandblast again, or you need to clean it with IvoClean, or you need to clean it with sodium hypochlorite. This is very, very important. Also, again, let me go back here on top, the etching time, 60 seconds for lucite reinforced, only 20 seconds for lithium disilicate. So it becomes critical to know which material you are using. Now, let's look at what options we have. Okay, so we have different materials. We have different options for cementation. So let's look at, okay, I think, yeah, let's look at something called a dual cure activator. Now, this is something which is used to convert a bonding agent, which is light cured, to dual cured bonding agent. So do we need this in every case, or don't we need this? This is something which is very critical for us to understand. So let us look at how you would treat these crowns and how you would cement them. So this first one I'm showing you is a lithium disilicate Emax crown, which I would need to condition, as I had said, with hydrofluoric acid for 20 seconds. Okay. If instead I was using a zirconia crown, I would need to sandblast it. After trying, I would need to either sandblast it again or clean it with IvoClean or sodium hypochlorite. Okay, so this is the treatment for these two separate crowns. Now, I need to bond them, right? So for bonding them, again, I have two options. If I am using a bonding agent like Premium Bond, which doesn't have a primer, I need to use a primer followed by a bonding agent, or I could directly go in for something like single bond universal, which has silane and MDP, so it bonds directly to the crown, right? So that is the second option. So the surface treatment would be the same, but when it comes to bonding, depending on the material I choose, I will either need a primer with the bonding or I won't need it. Next, I have two options in resin bonding. One is self-adhesive and one is multimode. That is, one is self-adhesive and one is adhesive, as I had explained earlier. So for a self-cement, you don't need to do anything on the tooth. You don't need to bond it. The cement by itself will bond to the tooth. Whereas if it's an adhesive one, then you will have to separately etch or bond the tooth. Right? Now, again, two different companies, two different products. So what you have on top is the GC one, and what you have below is the 3M product. Now, there's a reason I'm showing you this. So as I said, if you're using multi-mode, you need to bond the tooth as well. So remember, you have treated the crowns. You have used one of these two options on the crowns. So the crowns are now having bonding agent on them. Now, if you're using self-adhesive, then you don't need this step. But if you're using the multi-mode, then you need this step. You have to bond the tooth also. Now, once you applied bonding on this and you applied on bonding on this, now the question is, do you cure the bonding on both or not? Now, the best results would be if you cured it. However, if you cured the bonding on this and the bonding on this, very often what you will find is that the crown won't fit. Because if you are not careful during thinning of the bonding and you have some bubbles which remain, or the thickness of the bonding agent is too much, then the crown will not fit. So ideally, I want a scenario where the cement which I am using should induce the setting of this bonding. So if this cement, any of these, would induce the bonding to cure here and here without a separate light cure step, that would be the best thing for me. Unfortunately, it doesn't happen with all materials. So most materials, you would have to separately light cure this and separately light cure this. Or the other option is, remember I spoke to you about a dual cure activator. So another option is, for the bonding system which you are using, you need a dual cure activator. You mix the two together, then this bonding, instead of being light cure, now becomes chemical cure. So it is a very complex scenario. So if you look at it next, whether you need to light cure both or not, again, depends on the cement and the bonding agent combination, and also depends on whether you choose to use a dual cure activator or not. Okay, is that complex now? It is complex. So remember, if you are using the self-adhesive cement, no bonding step required here. You treat this, you cure this, and you cement it. That's it, done. If you are using the multi-mode adhesive, then you need to bond this, you need to cure this, you need to apply this, and you need to cure this, or you need to use a dual cure activator. Okay, so I know it's complicated, but that's the way it is. Okay, so can I use bonding of one company and cement from another? Ideally, no. Ideally, no. Ideally, I would stick to the bonding agent and cement from the same company. If you had to, you would want to come cure activator and then use it. So I'm using a 3M bonding here and a GC cement here, then I would prefer to do this to ensure that the bonding sets completely. Now again, whether this should be light cured or not. Now say a company like GC insists that if possible you should light cure this. They get best results for that, their cement if it is light cured. So the choices which are available to you are myriad. There's so many. And unless you understand the materials that you are using, the failure rates are going to be high, especially with ceramics. I have really tried to explain a very complex thing to you within the last 20 minutes. I needed much more time to elaborate on this, but I hope I have been able to put it across to you. Now, going back, remember I told you, two of the companies, the silane is within the bonding. That is for clear fill and for 3M, single bond. Is that silane enough? Now, that is the issue. Or a separate primer, is it still important? Now, remember, most manufacturers don't add silane, only two companies, because it is difficult to incorporate silane without spoiling the chemistry. Now, I am of the opinion that when it really matters, now say for example, not a crown or a bridge, but if I'm doing veneers, the only thing that holds the veneer in place is the bonding agent. And that bond is what contributes to the success. So when it is really critical for me, I would use a separate silane coat even if there is silane in the universal bonding system. Now, this is my personal opinion, and there are studies which show also that it is much better to use a separate silane coat in spite of there being silane in your universal system. So this is a choice which each one of you all would need to make, but there is evidence to show that using a separate silane works. So personally, if I am going for a kind of higher retentive surface like a crown or a bridge, then I might choose to miss the silane because the silane is already in the bonding system. But if I was doing veneers, I would apply a separate silane coat. Last but not the least, please understand one thing is that all bonds fail over time. And if you don't do the job properly, your failure is going to be higher. So if you compare 24 hours and after 10,000 cycles, now if you look at bonding to enamel and dentine, it is kind of more or less similar. But if you look at bonding to lithium disilicate here, can you see these bond strengths fall off very rapidly after 10,000 cycles of thermocycling? That means after use, the bond strength tends to be lower. This slide for a particular reason. There are many other studies I could have shown you, but the reason is, remember we spoke about self-adhesive cement and adhesive cements. And the advantage of using the self-adhesive cement was that it bonds to the tooth by itself. You don't need to separately bond it. But the point is that the failure rate over time would be higher for the lower bond strength. So when I really want a very, very good bond strength to the tooth, I would prefer to bond the tooth also, just as I bonded the crown, and I would want to use an adhesive cement. Okay. So now if we come back to this chart, which I had shown you earlier, So if you look at this in toto now, what you will find is there are some, like say all bond universal, which do everything. There are some like Scotch Bond Universal, which does everything, but it needs a dual cure activator if it has to be used with another company's cement. Remember, they gave you the example of using 3M bonding with GC cement, whereas some you cannot use without separate primer and you cannot use without dual cure activator at all. So there is a lot of difference between different companies and different products, and you need to actually look at the details of whichever product you choose to go in for. To sum up, what are the recommendation I can give you? Selective enamel etching. I told you it is very critical to get an enamel seal at the margins. If you can't etch as in the present condition, maybe increase the time of self-etch from 20 to 40 seconds. Rinse for 10 seconds. Apply the universal adhesive with a rubbing motion. Again, active application unless your system specifically asks for a regular application. Evaporate the solvent, I have mentioned, for slightly longer. This is required for 2-3 reasons. You want the solvent to evaporate, you want the bonding agent to be thinned out, you want the oxygen inhibited layer to be removed, and you want your bonding layer to be thin. You don't want very thick. If you have very thick bonding layers, the failure rates will be higher. And okay, this is an optional thing. So remember, we spoke about 2-step and 1-step systems. I told you about self-etch system Clearfill, which is 2-step. So in that, the second bottle is actually a hydrophobic bonding overcoat. Different companies give you a separate hydrophobic bonding overcoat if you want. If you add that, the bonding is more stable over time. Something I didn't discuss in detail, but if there are any questions on that, I can handle that later. So same thing, single bottle systems tend to have bond failures over time. The 2-bottle systems where the second hydrophobic overcoat is added will have longer term results which are better. So obviously, if you etch enamel, I told you, selective etch would give you a better result. But again, in the time of COVID, I would suggest that you be very careful about etching and washing. The 3-way syringe is one of the most underrated things when it comes to aerosol. You need to be really careful about aerosol from a 3-way syringe. So I would prefer still to go in for a self-etch system and maybe use a chip blower instead of a 3-way syringe. And of course, the use of a rubber dam would be mandatory. Now, as I mentioned, not all bonding systems are compatible with all cements. So mixing and matching companies, you might end up with a situation even with a dual cure resin composite, which is used for say core buildup, where you may not get the resin curing because of the chemical cure. So this is something we need to understand. Mixing and matching is not probably a good idea. See, when it comes to composites and bonding systems, you can mix and match. So I'm using bonding from one company, using composite from another, fine. But when it comes to cements and bonding, I would be more careful. Okay, so again, you want to cure the bonding within the crown and on the tooth before you cement the crown. Some companies ask that you should. Ideally, the bond strength would be better. But remember one thing, if you don't do it right, your crown will not fit. After you cured the bonding, when you try to put it back and cement it, it is not going to fit. That's a very real possibility. So one of the options which I have given you is you could use a dual cure activator. So you don't have to cure it, but it will still get cured efficiently. Use recommended adhesive cement combination. So this is something I really stress upon. Stick to whichever manufacturer you want. Stick to that manufacturer bond and the resin cement for that manufacturer. And checking your light is something which is very important. I mean, if your light is giving you curing intensity less than 500, then you really need to be thinking about buying a new light. 800 is probably the bare minimum you need. At the same time, having very, very high intensities like 3000 and all is probably also not a good thing. So 1000 to 1200 would be a great light intensity to have. You need to get your lights tested, because when you're curing through crowns, you're going to lose some of the intensity. So if I'm doing veneers and all, I'm curing through the veneer, you're going to lose some of the intensity. And the one thing is that curing for longer, as long as you make sure that there's no heat generated, cannot be harmful, but curing for lesser than required can definitely be harmful. So bearing that in mind, even if you're using a dual cure cement, for example, or a dual cure core buildup material, for example, have extra light, no problem. I sometimes have two lights simultaneously, one from the buccal, one from the lingual, or one from the lingual, one from the occlusal simultaneously. So you have double the intensity. And also, just increasing the time is not going to make it go deeper. So if you have a crown which is 2.5 or 2 millimeters thick, and you think that, oh, okay, I'm going to use a light cure system and I'm going to go on curing for longer and longer and it will cure, it doesn't work. And last thing, again, use self-curing or dark curing wherever you think curing intensity is going to be inefficient. You know, you're working in the second molar areas where your light can't reach more efficiently, then always think of using a system which has got a self-curing or a dark curing option. So thank you very much for being patient and for waiting with me through that shutdown. Never in my life have I ever had to do that. I don't know what was wrong with the system today, but I'm glad that we could still get through that and manage. Thank you very much. If there are any questions, I'll be happy to answer them.
Yes, sir. Thank you so much, sir, for a truly enlightening and informative session. You have cleared almost all our doubts regarding the bonding. There are still some queries from the participants. So now I request Dr. Mahalakshmi ma'am to take over with the queries.
Thank you so much, Dr. Arvind. I just can't think of what you have missed out, because you have just sort of covered up every aspect of bonding that I could think, except probably one, but questions that have come up from the audience. But since we are short of time, we will keep the question answer sessions to about 10 to 15 minutes. So if whatever you can possibly answer during that time is enough. The first question was from Dr. Himani Thawle, who asked that does the type of solvent, that is acetone or ethanol, affect the bond strength of the restoration?
Yes, it does. And the clinical relevance of the drying step also becomes very important. So mostly ethanol and water is used. Some systems are using acetone. So the instructions, it becomes very important to follow. For example, some systems may ask you, as I said during the lecture, that you need to apply and leave for some time, whereas some systems will tell you you need to scrub for 20 seconds. Now, the solvent will also play a big role in this. The entire composition dictates that. So yes, the solvent does matter. Generally, ethanol-water combinations tend better. That's my personal opinion. But acetone also works. So yes, the answer to that is yes. Clinically, it is very relevant.
Okay, the next question is from Dr. Avisha. According to you, which is more preferable, 7th or 8th generation bonding agent?
Okay, so I'm going to answer this in a particular way, right? So I am my father's son, right? So that means that I am next generation after my father. But if you ask my father, he'll probably say that I'm useless. So the next generation does not necessarily mean better. I need everybody to understand this. The next generation only means that it is a newer product in evolution. I generally do not talk about generations at all. I think I'm more of the follower of Meerbig's classification, where you talk about etch and rinse, self-etch, or now multi-mode adhesives. So if we look at 8th generation, I would presume they're talking about universal adhesives as opposed to 7th generation, which would be single bottle self-etch adhesives. So 8th generation would probably be better, but that doesn't mean anything, because some products in the 8th generation may not be as good as something from 7th generation. So one more thing I would like to add. So 4th generation was the 3-step etch and rinse. In terms of longevity of bond, is probably still the gold standard. So just having a new generation doesn't necessarily make it better. That's my take on this. Sorry.
Yeah, the next question now is from Dr. Sachin Bengal. Is it recommended to apply a layer of bonding agent over a final restoration to achieve a gloss?
The answer is no. Yeah, the answer is no. So let me just make a little clarification. There are two different things available. One is called a surface sealant, and one is bonding agent. A bonding agent is a pure hydrophobic bonding agent. So there is some theory that after you finish polishing, there are some micro cracks which are produced. So they talk about etching the margin of the restoration again and using a surface sealant. So there is some evidence of that. But to get a polish or to protect the restoration, using a bonding agent on top is probably no use at all, because it's not going to last for very long. It wears off very fast. So I think that should answer the question.
Another question from Dr. Prajakta is the predictability of the bonding is better for enamel or dentine?
Obviously for enamel.
Okay,
The bond strength is higher. Yeah.
I think I'll move to the next question because there's no more arguments on that. Dr. Urvashi asks, what is your view on the use of bioactive cements and self-adhesive composites which claim to bond effectively without the use of bonding agents? Bioactive cements and self-adhesive composites.
Okay, I would reserve comment on self-adhesive composites. I don't think we've reached a stage that they're really clinically that efficient. So I'll reserve my judgment on that. But bioactive materials, I think, are really important, and they are very, very useful in practice. So going back to the caries management strategies, which I spoke about earlier. So in selective caries removal, now there are two options. So basically you remove the caries infected dentine and you're left with caries affected dentine. And now you have two options. You could either restore it with a bioactive material, which will encourage the caries affected dentine to be remineralized and become really hard again. Or you could directly go in for a restoration with bonding. Now, these are two options which you have, and each one would have to take a call depending on a clinical scenario. So bioactive materials are really fantastic when you want to do selective caries removal, and whether it's biodentine or MTA or whatever material, or even Theracal. So they are a great thing to have. But one point I would like to make here is, do you want layered restoration? So do you want a sandwich restoration, or do you want a Theracal base followed by a composite? So most data seems to suggest that layered restorations fail more. So there is a lot of research done by somebody called Nick Opdam. You can look it up, clinical studies, even 7-year follow-up. So he will show you that sandwich restorations fail more than regular restorations. So both these things, I'm putting it out there. You need to decide what works best for you.
Yeah. So, Dr. Shreya Shahu, which bonding strategy is better while using universal adhesive? Self-etch or etch and rinse?
Selective etch.
And Dr. Chetna Makre asks, what is your opinion regarding Icon product for remineralizing white and brown spots?
Yeah, excellent. Unfortunately, I couldn't show you the post-op for that one case I wanted to. Icon is really good for remineralizing. It's a fantastic thing to use, though it's very expensive. So I don't know how easy it would be to incorporate it into regular practice, but it works very well. You could even, one of the things is in stage 1 of caries, even proximal caries, Icon is really wonderful in remineralizing that and ensuring that you don't need to go for the restoration, which, I mentioned right in the beginning of the lecture. You don't have a restoration, the risk of reintervention and extraction is not there. So yes, Icon is a great product.
Dr. Shreya again, does increasing the solvent evaporation time enhance the quality of bonding?
Yes, it does.
It does. So which bonding is preferred on hypocalcified teeth by Dr. Gautam?
So now one thing is, I did mention that using sodium hypochlorite for deproteinization is one very effective strategy when working with hypocalcified teeth. Between etch and rinse and self-etch, there has not been much difference that has been seen, basically because there are very few studies which have been done on molar incisor hypomineralization. There is a certain group of researchers which has done most of this research. So there is not much evidence which both would work, but yes, you would want to incorporate hypochlorite as an additional deproteinization step before the bonding.
Dr. Urvashi, how is bonding different in non-vital teeth compared to vital teeth? I think this is a very vast question to ask. So
I think that I would reserve judgment on that. It is very different. The structure of the dentine, the moisture, everything is very different.
I think you need another 1 hour to explain this, right? Dr. Sahitya here. What type of restorations are used for various non-carious cervical lesions and on what basis to select?
Okay, so, when you have a lot of sclerotic dentine present, maybe an additional step of EDTA for 2 minutes with the 17% EDTA before you do the bonding might work. Otherwise, I mentioned, try to have all your margins in enamel, and a two-step self-etch works very well, or a selective etch also works very well. Both of these are efficient. In terms of material choices, my choice is still composite, unless you don't have margins in enamel, in which case I might go in for glass iron.
So what is your take on the selection of crown depending on remaining tooth structure, with irrespective of whether it is anterior or posterior teeth? This is by Dr. Manjunath. What type
I cannot make it irrespective of anterior or posterior. Not only just anterior or posterior, I would think that one of the most underrated things is calculating the occlusal load on any structure. The failure is occurring because of the occlusal load, not only compressive load, but shear loading. If you look at ceramics, the flexural strength and the fracture toughness is much more important than, say, compressive strength of the material. So, choice of material would depend on the requirement occlusally. So the higher the requirement occlusally, let's say if I'm doing a second molar, in a second molar, a monolith or even say a precious metal onlay would be a far better choice in a second molar. Whereas if I'm talking about an incisor or a premolar, I would go in for a bonded Emax. Now, one of the fallacies people have, and I myself showed you a slide where I said Emax is strength of only about 402, 480. But the example I give you is the sunmica which you put on wood for furniture. If you take a sheet of sunmica and just bend it, it snaps. But once I stick it to furniture very well, I need to break the wood for the sunmica to snap. And the same logic applies here. So if you bond the Emax restoration to the tooth well, then it doesn't fade, even though the strength is lower, because you get a monoblock. So the choice of material would depend on the occlusal stress, but by and large, I would go for bonded Emax for anteriors. For posteriors, I would go in for onlays, which are monolith Emax, maybe CAD instead of press. Now, again, the CAD improves the strength. The manufacturing process also dictates that. And if I'm going for, say, second molars, I might want to use, say, a monolith zirconia. But the moment you use monolith zirconia, you're adding a lot of stress to the masticatory apparatus. So that is also something. And the wear on the opposing tooth is also higher. So there's so many different things that you need to think about when selecting a crown material.
I think we have a few more questions. I think you can take up. Can we take up Deepika? Yeah, I'll ask you the question from
Yes,
Dr. Agarwal.
Yeah,
in one of your slides, you had mentioned that you said to increase the time of the self-etch bonding systems. So how much increase would you recommend?
Double, 20 to 40 seconds.
Double the amount.
Yeah.
Right. Now, what is your, just a minute. One from Dr. Balagopal. Have you ever used universal adhesive after acid etching the surface? If yes, in what condition?
Yes, we have used total etch for veneers and all. I used universal adhesives after acid etching the surface, and they work very well. There's no problem. It works in.
The question is, what do you do after the etching? Do you completely dry? I preferably mean completely dry, or you keep it as moist?
Moist. Okay. Now, thankfully, most universal adhesives are not as susceptible to this as previous generation systems were. So moist would be the way to go, but the addition of the 10 MDP actually makes them a little more moisture tolerant. So it's not as, most of the bonding systems are not as affected by the dryness or the wetness compared to earlier. But given a choice, I would leave it moist if I was using a total etch technique.
And there's a couple of questions on how can we use self-etch bonding system on effectively on caries dentine, and what is the protocol for caries dentine? There are a couple of questions on that. So some light on that. Probably they missed.
Okay, so
question.
Okay, now one of the things is if you look at the depth of etch, with etch and rinse and self-etch. The depth of etch is much lower in a self-etch. I've shown you that in most of the systems, the pH is about 2, it goes up to 3. So the hybrid layer, and this is something I didn't talk in the lecture because I presume everybody knows about it. So the most critical thing in bonding is to get the hybrid layer. Now the thickness of this hybrid layer also depends on whether you use etch and rinse or whether you use self-etch. In self-etches, this hybrid layer is usually very thin. It's not very thick. It won't be 5 to 10 microns. So it doesn't matter as long as you get a hybrid layer. However, in caries affected dentine, what happens is the mineralized content is already lower. So when you're using self-etch, what tends to happen is that this acid-base resistant zone and hybrid zone which you want to create is not as efficient. So given a choice, I would want, I showed you, there is data which says that etch and rinse would be better on caries affected dentine. But when you're etching dentine, your bonding system has to be perfect. Otherwise, you will end up with sensitivity. So it's a choice that you need to make. Now, even if you're using self-etch, and even if you have a little lesser hybrid layer and it's not as efficient on caries affected dentine, the most critical thing, and I've been emphasizing it most, is to make sure that you get a peripheral enamel seal. Once you get that, the bond stability is much higher. So it's a choice you need to make. If you want to have a much better bond, you would go in for etch and rinse, etching the dentine also, but it needs you to be very careful with your clinical technique. That's where this wetness and dryness would be much more important. I can't hear you, Doctor. Yeah.
What is the protocol? Now, again, there are a few questions on protocols on subgingival restorations and on teeth that have been bleached. They are two separate questions, but I thought
okay, so subgingival restorations, the protocol would ideally be deep marginal elevation. That would be the way to go. So DME is a protocol in which you want to actually convert a subgingival into a supragingival margin. It could be done in multiple ways. One of the easier ways to do it is to do an open sandwich where you place a glass ionomer on the subgingival margin and raise it. The other option would be to isolate the margin, bond it, use a high viscosity flowable composite to raise it to a higher level, and that's basically deep marginal elevation. This would be the two options which you would use. Again, the bond you would get to the cervical margin would depend on what kind of tooth structure you're looking at. If it's primarily cementum, you're not going to get great bonding with composite. So there, maybe glass ionomer would be a better bet. A nice capsule using a resin modified glass ionomer to raise the margin and make it supragingival. As far as bleached teeth is concerned, as long as you wait for 2 weeks, you should not have much of a problem with bleached teeth. The bleached teeth, the only thing is you don't want to do bonding immediately after bleaching. You want to wait for some time before you do the bonding procedure. That's about it. And otherwise, the bonding works as efficiently if you wait sufficiently.
wow, thanks a lot. I think I have managed to finish all the questions in spite of going beyond the 15 minutes that was allotted. But I couldn't stop at removing a few questions. So thank you very much, Dr. Arvind.
Thank you, Dr. Mahalakshmi.
Wow, wasn't that truly an academic treat? Thank you so much, a speaker for today, Dr. Arvind sir, and a moderator, Dr. Mahalakshmi ma'am. So on behalf of our entire Department of Cons and Endo from BSP and Nagpur, we would like to present a certificate of appreciation to our speaker and our moderator for today. Thank you so much, ma'am. Thank you so much, sir.
Thank you very much.
I'd also take this opportunity to introduce to all of you a contest which is called the Masket Contest. So you can send your entries. The details are given on the screen. It needs to be sent before 25th of July. Okay, and you can note down the details here. We'll be displaying some pictures. Yeah, so you can take, innovative pictures and selfies like this and send it to us. So also apart from academic activities, we wish to highlight those individuals in our specialty who have enriched their lives with other co-curricular activities as well. So we as a specialty have a constellation of endo stars in our galaxy. Today, let us take a glance at them. This is Dr. Elakshi More, She was a PG student of Department of Cons and Endo at VSPM. She has won Mrs. World runners-up title. She is an actress and a model too. We are proud of you, Dr. Alakshi. Now we have come to the end of today's session. I request Dr. Varsha Uttarwar ma'am to propose the vote of thanks.
Thank you, Deepika. First of all, we would like to thank our speaker for today, Dr. Arvind Shenoy, for a wonderful session and a highly informative one. We would also like to thank our moderator for today, Dr. Mahalakshmi ma'am, for sparing her valuable time and joining us, ma'am. Thank you. Then many of the eminent faculties in our specialty have joined us today. We would like to thank them and hope that they are a part of this journey throughout the month. We'd also like to thank all our participants who have joined us for the session. So with this, we conclude the session and see you tomorrow, same time, that is 11 a.m. for another informative session. Have a great day.
Thank you, everyone. With your permission, I'm ending the meet. Thank you.
And she is